morning. Can you all hear me? Yes? Very good. Okay. My name is Trung. I'm a physical therapist here at John Knox Village. And today I want to talk to you about the services we have here for outpatient rehab at Oak Park Senior Services. That's located in the same building as the pharmacy and the clinic. So why should you come to us for your outpatient needs? Well, like I said, we're here on site. It's really close by. You can drive or take your car or the golf cart and drive over. You can take transportation, John Knox Transportation, to come over. So it's really close by. And what we also really try to focus on is what your individual needs, what your individual goals are, and try to specify programs to help you meet those goals. So we make sure to try to use up-to-date evidence-based practice to develop these programs and treatments to help you. We have state-of-the-art equipment. So we have here the Neurocom Balance Manager. So utilize that to assess your balance, gives us more objective data. There's a static force plate. These walls actually move, so different scenarios, and see how your balance is in different scenarios there. We have, can't really see it here, but this is it's not only just a treadmill, but it's our Biodex gait trainer. So on the treadmill here, we can analyze your gait. I can see whether if you're taking the appropriate step length, or if one foot is going longer than the other. And I can also tell if you're weight bearing evenly on each leg while walking. So I'm going to help you improve your gait that way. We also have the HUR equipment, or HUR machines, HUR. Those run on pneumatic pressure. If you've been to Valencia Landing at the fitness center there, they have those same machines as well. And the benefits of those machines is that instead of using the traditional machines of plated weights, that uses a lot of inertia to push that weight out, and by the time you get to the end range, it doesn't take a lot of pressure to kind of get to the end range, and you get this uneven pressure throughout the arc of the motion. With the use of compressed air, it actually eliminates that inertia, and that pressure, that air pressure, is even throughout the arc of the motion. You may notice on the gauge, the needle, it'll kind of bounce up and down a little bit because that pressure is being applied as you go out through the arc of the motion, and it will be less stress on your joints. And also the continuum of care. So we have different levels of care for therapy here at John Knox Village, which I'm going to go over in the next few slides. So for example, you're at home, you're not feeling really good, a little bit dizzy, all of a sudden you fall down, you land on your bottom, feel a lot of pain, you're brought to the hospital, or you decide to have surgeries, decided that your knee pain is just too great, you can't bear it anymore, you decide to have an elective knee joint replacement surgery. And so you're in the hospital under their team of care, and once you've been stabilized, you may not be ready to go home yet. Maybe you're not moving independently, or maybe you're still in some pain. The next course of treatment is to bring you to Majestic Oaks for inpatient rehab. So at that point, maybe you're not independent with your dressing or showering. You can't get out of bed by yourself yet. You're not safe to walk on your own yet. So our rehab team at Majestic Oaks will work on all those things to get you more independent and safe to go home. So once you're ready to go home, we will set up a home eval. And so one of the evaluating therapists will come and meet or bring you over to your home, and a representative from home health as well will come over and evaluate how you move around. Are you safe at home? Getting around your bedroom, bathroom, living area, kitchen. Also to make note of any modifications that may be needed, such as if there's throw rugs that need to be removed, or some clutter that needs to be removed, if grab bars need to be installed in the bathroom, or if you need like an elevated toilet seat, we'll try to make those modifications happen so that when you return home, you'll be safe. And so after being discharged from Majestic Oaks, going home, you may have orders for home health services. So the home health nurse and therapy team will come and make sure that when you're at home, you're managing your medications properly, and also getting around your home safely, doing the things that you should be able to do prior to the hospital on your own safely. Then after that, you're independent. Let's say you graduated from the walker to the cane, but you're still a little bit unsteady. Even though you're independent, you're still a little bit unsteady. You want to get rid of that cane. That wasn't what you were using before. You'll get orders to come and do outpatient therapy and to continue on to get stronger and more steady on your feet. In some instances, you may go home and may not need home health services, or in some instances, you go to the hospital. Let's say they didn't find anything broken, but you're still a bit unsteady and weak. They may just send you home from the hospital and send orders for outpatient therapy. So you met all your goals, you got rid of the cane, you're stronger, you're more steady and more balanced on your feet. So the next thing I'd like to do is to encourage you to keep going on with your exercises. So along the way, we'll give you like a home exercise program to work on and continue to work that at home. But also what we can do right before being discharged from outpatient therapy is to meet you at one of our fitness centers, which we have two now. We have one here at the Commons and one at Valencia. So we'll meet at whichever one is appropriate for you, go over the equipment that's appropriate for you to utilize and continue with, the appropriate weights and repetitions, and go over that so that you're using that safely and able to maintain your strength. One of the questions I get right when people finish therapy is, well, how long am I supposed to keep doing these exercises? And my answer is, for the rest of your life. So again, we have two fitness centers. There's really no excuses. You can see here the new step. We can teach you how to use that. We can teach you how to use the HER equipment. Teach you how to use the recumbent bike, arm bike, elliptical machine, whichever is appropriate for you. If you need like one-on-one help or one-on-one attention, home health does have like private home health services where you can call Justine extension 1402 and have that set up for you. And also Talina, our fitness coordinator, she's great as well with her classes, so that's something to look into as well. Balance and stretch, or I think we also have Tai Chi classes, so different other classes that you can get involved and to keep yourself active. We also have pools. If you like that, working in the pool, you can continue doing that. So there's many options for you to stay active. And that's just an overview of our continuing care here at John Knox Village. The next things I want to go over in a little bit more detail is our different therapy services, starting with speech therapy. So with speech therapy, we also have at Oak Park, and what we have is, it's called a FEES, Fiber Optic Endoscopic Evaluation of Swallowing. So if you have difficulty chewing or swallowing food or liquids, that can be evaluated and that can be treated for. If you have a low volume voice or a voice that's harsh or gritty, the speech therapist can work on that. Or if you feel like you're running out of air when you're talking, our speech therapist can work on that. In terms of language, if you're having difficulty finding words during conversation, trouble understanding what people are saying, they can work on that. And in terms of cognition, if you're having increased difficulty with memory, difficulty completing tasks that are familiar or complex, or difficulty with attention, and of course with speech, if your speech is slurry or stuttered, are unclear, our speech therapists can work on those. We also have occupational therapy at Oak Park. Occupational therapists, they work primarily on activities of daily living. So in like a subacute or inpatient rehab phase, you may have difficulty getting yourself dressed or bathed or toileting, that they kind of focus on those. Once you're more independent with that, and in a more an outpatient setting, they can help you with your upper extremities. So if you have pain with your hand or wrist or elbow or shoulder, our occupational therapists can do rehab for that. For example, if you fallen and landed and try to brace yourself with your hands and you end up with a wrist fracture, they can work on that. Carpal tunnel, trigger finger. If you're playing a lot of tennis or pickleball and end up having tennis elbow, they can help you with that as well. Our occupational therapists can work on visual perceptual training, also splinting and orthotics. So if you complaining of pain and numbness in your hands at night, then they can work on a splint to help keep your wrist in neutral, so that if you have carpal tunnel, that will help the nerves there not being compressed while you're sleeping. If you have suffered a stroke, another example, if you have suffered from a stroke and your hand and elbow tend to be kind of curled up like this, they can work on splinting to help open up and keep your hands out, stretched out, and also straighten out the elbow as well. Occupational therapists can work on recommendations for any other adaptive equipment and work on home safety as well. All right, so physical therapy, we work on everything else basically. So you have pain like in your neck or back, the lower extremities or hips, knees, and ankles. If you need to work on balance, we can work on that. If you had a hip replacement or knee replacement or shoulder replacement, you can do rehab for that. If you have osteoporosis, we have a certain exercise program to help you decompress with the vertebrae so they're not as pressing as much on each other. We utilize different techniques such as manual therapy. That's, for example, joint mobilizations, scar tissue mobilizations, soft tissue mobilizations, basically ways to help move your joints, move your muscles better, help decrease pain, improve range of motion. And the use of modalities, for example, ultrasound or electrostimulation, we can utilize that to help decrease pain. Other services we have under physical therapy, I just want to highlight a little bit, and I'll go a little bit more detail about these services. So LSVT BIG, that's a program that I'm certified in to help people with Parkinson's. So if those people having trouble with walking or getting out of bed, they feel like their movements are small, we emphasize on big amplitude movements to help them move better. I'll go into more details about that later. I'm also certified in vestibular rehab and concussions, so symptoms of dizziness or vertigo. If you feel like when you get out of bed, you feel like the room is spinning, we can work on to help get those symptoms under control, help with your dizziness, and help you be more steady on your feet. And as I mentioned so this is an example here of LSVT BIG. So what she's doing there is taking a really big step and just emphasizing big, large amplitude of movements. Over here, this is an example of the Epley maneuver. That's basically, you might have heard of the crystals falling out of place, and that results in vertigo. So that's one maneuver, and there's another maneuver to help get those crystals back into place. And then our Neurocom balance manager, again, to assess your balance. That helps me identify which areas of balance that we need to focus on and then work on those. And I just want to highlight something really quick. So this is the LSVT global website. You click on find a clinician in your area. LSVT loud, that's for speech, and LSVT big, that's for PT or OT. Type in zip code. Hit search. And then you can see the therapists in your area. Here's me. That can do LSVT big. And over on this website, the American Institute of Balance, to work on, like I mentioned earlier, dizziness and vertigo. Find a certified provider. Zip code, search. And then you can see me here, and along with other therapists in the area that are certified in vestibular rehab. So this is just some examples of conditions that we can treat in physical therapy. So it's not an exclusive list, it's just some examples. And you can see a wide variety of orthopedic conditions, so joint replacements, fractures, if you had a back surgery or neck surgery, we can work on those, and also neurological conditions, so stroke, Parkinson's, again, vestibular, such as vertigo or dizziness, we can work on. And so to answer the question, how do you get started with physical therapy? So first, or one option is you can get a referral from your primary care provider, whoever that is, if whoever you see, whether it's Dr. Hill or Dr. Emilnini or Martha Collins, your primary care provider, you can see them and get a prescription for physical therapy. Or sometimes you go to an orthopedic office and you discuss your options of the kind of pain that you're having, and you decide you don't want to do surgery, you don't want to be under anesthesia, you don't want to get cut open, you rather do therapy, and they'll send you over here. Another option for you is direct access. So this is available in many states across the United States. And here, specifically in Florida, you can come to physical therapy directly without a referral for up to 30 days. So for up to 30 days, we can treat you without a physician referral. After 30 days, that's when we have to call a doctor and get a prescription. And per Medicare, so Medicare beneficiaries, you have to be under the care of a physician or non-physician practitioner, such as Martha Cullen, for those therapy services to be covered. So a couple options for you to get started with physical therapy. So next I want to talk about pain and how we can help you with pain. So according to the International Association for the Study of Pain, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. What I want to highlight is actual versus potential tissue damage. So when we think of pain, we think of we broke our bone, we tore a rotator cuff. But another way, or new way of thinking of pain, in addition to that, is pain as a warning signal of something, a warning of something that's could be going wrong, or potential damage, and that's you can use that as a warning signal to protect us from injury, from further injury. So with this new understanding, we now know that feeling pain does not necessarily mean a physical injury has occurred. You can see on this list here of different sources of pain in the elderly. I'm not going to read that, but you can see it, how it can come from neurologically, from stroke, or an actual injury like a fracture, or even from cancer. To categorize pain, we put in two different categories: duration of pain and cause of pain. So duration of pain, so we have acute pain versus chronic pain. Acute pain generally doesn't last more than 3 to 6 months. It usually comes on suddenly and is caused by something specific. It could be from an injury or surgery. But chronic pain, that's when the pain lasts longer than 3 to 6 months. The pain may even continue even after that tissue or injury that caused it has gone away or has been healed. Chronic pain may not be associated with the disease process either. Cause of pain, we have nociceptive pain, so that's stimulation of the pain receptors. That's usually localized and responsive to treatment. That's definitely caused from a disease process such as trauma or medical treatment like surgery. There's also neuropathic pain where there's pathology with the central nervous system or the peripheral nervous system. Examples are diabetic neuropathy or phantom limb pain. That's usually diffuse and less responsive to analgesic medications. So when we talk about pain management, it's a team approach. So with your physician, pharmacist, therapist, looking to help minimize the pain as much as possible. There's some instances where the pain may not be gone away completely. I know a lot of time when we feel pain, we want that just to be gone. We want that gone yesterday. But typically with therapy, we're looking to see if we can get that pain as low as possible. So from day one, your pain is at a level of 8 or 9 out of 10. Hopefully we can get it down to maybe about a 2 or a 1 out of 10 pain. Something that's more manageable and something not as harsh. So according to the CDC, non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. The contextual evidence review found that non-pharmacologic therapies such as physical therapy, weight loss for knee osteoarthritis, psychological therapies such as cognitive behavior therapy, and certain interventional procedures can ameliorate chronic pain. So there's been a big crisis with opioids, as you may know, and being overprescribed. The pharmaceutical companies are pushing it so they can make money. So not to say that they don't have a place. Maybe they are needed, like addressing pain initially. But again, it's to this kind of get over this quick fix solution and try to focus on something that it won't be as addictive. So the CDC says there is high quality evidence that exercise can help for hip and knee osteoarthritis to help reduce your pain and improve your function. That include aerobics or weight resistance training, or even doing water aerobics as well. So we're, as therapists, we're looking to determine how to limit the effects of pain, not only to focus on the symptoms of pain, but also adjust or make improvements on patterns of movement that won't exacerbate that pain. So we're looking at movement patterns that are causing the pain, so we're going to try to figure out ways how to eliminate or adjust those movements to help eliminate the pain. So we can do that through exercise, like stretching, cardiovascular fitness, strength training. I mentioned earlier about manual therapy, and also use of modalities as well to help with reducing pain. Motor control exercises, that's just a way to help restore according to the efficient use of your muscles to help control and support your spine. And also education on lifestyle changes, improving your posture, introduce proper body mechanics, ways to help save your back from getting injured by using proper lifting techniques. Also stress management and better sleep as well. So when people come and start therapy, they immediately think, oh, we got to work hard, no pain, no gain. And I have to immediately tell them no. That's not true. I'm not trying to make your pain worse. You may feel that way. You may feel a bit sore afterwards, but truly and honest with you, I'm not trying to make your pain worse, okay? What I want you to really think about and remember is not no pain, no gain. No pain, no gain. Know how or what is causing your pain, what movements, and know how to lessen those pain effects, how to make yourself stronger and more aware of how to move better and reduce anything that will cause and contribute to your pain. So we start low and go slow. I'm not trying to ramp up and try to have you, run a mile in 6 minutes. You let me know if what we're doing is maybe a little bit too high intense. We're going to adjust it, to your needs. So another thing I'm also responsible for is following up on falls. If somebody here at John Knox Falls, security and resident nursing is alerted, and they come and check on you, make sure you're okay, if you need to go to the hospital or not, and they let me know too, and to follow up and see if there's anything that we can do to help prevent falls. So whether that's, again, modifications at home. What happened here? Looking to make any modifications at home to see if there's any tripping hazards, or look to see if we need to improve your balance or strength. So 1 in 4 Americans over the age of 65 fall each year. Falls are experienced by many older adults, as you see by the ratio. It's a common experience, but it's also a quote-unquote normal part of aging to manage fall risk. It's not normal. Falling is not normal. It's not normal, and it's not part of normal part of aging. Just want to emphasize that falling is not a normal part of aging. So a fall is an unplanned descent to the floor with or without injury. That includes slips or trips as well. Basically, you're on a lower surface than when you didn't intend to be there. So I have some handouts from the CDC in the back you can grab on your way out on what you can do to prevent falls. So exercise. You can talk to your health care provider or pharmacist to review your medications. So there's some instances where some of the medications have some side effects and cause you to feel dizzy. So you just want to review that with your health care provider. Make sure your vision is good. So get your vision checked annually. And also, again, make sure your home is safe. So free of clutter, or different assistive devices or grab bars if need be to help you, or bed rails to help you get off and on the toilet safely or get out of bed safely. So in order to find out what your fall risk is, you can come see me. I can do a fall screen. I can do a quick test and see what your balance is. And there's also on the back handout a little checklist, yes or no questions. I think if you score 4 or more points on that, you may have a risk for falls. So that's something you either can discuss with your physician or come and see me, and we'll get treatment for you. So again, to emphasize that what we do is give you an individualized attention and a plan to help you achieve your goals and meet your needs. And I know the big thing with falls and fall risk is not only just improving your home environment, but to improve your balance. And so we have different types of balance. So we have this steady balance or static balance where we maintain steady on a level surface. We have reactive balance, so if someone kind of nudged you by accident, your ability to recover from that perturbation. We have anticipatory balance, so if you're trying to reach for something because you know it's a little bit farther away, you can anticipate that your center of mass is going to be over your base, out of your base of support, but you can still maintain your balance by reaching for that item. And dynamic balance, so able to maintain your stability when you're in motion. So our balance systems comprise of different components. We have our sensory. I'll go a little bit more detail of that, but basically that's input, and that gathers all that information and brings it to your brain for central processing. And that information is brought out into our motor systems, so our neuromuscular and musculoskeletal systems that carry out the output of that information to make the adjustments needed to stay balanced. Cognition is also important for balance, so ability to stay attentive, make judgment calls, also to multitask and filter out different distractions. So for example, you're walking from your kitchen, which is tiled, you're holding a cup of coffee, you're moving into your living room, which is carpeted, and then all of a sudden your dog comes up and starts jumping on your leg, excited to see you. You have to do all that to maintain your balance, not fall, not spill your coffee, okay? So again, going back to our sensory systems, a little bit more detail here. It provides input, it's peripheral input, and it's divided into three systems. Our visual system, so the use of our eyes. Our somatosensory system, those are joint receptors in our ankles and hips. And our vestibular system, that's an apparatus in your inner ear to help you stay balanced on uneven surfaces. So all that information's input from those three systems is brought to your brain for central processing. So the cerebral cortex, or your brain, that contributes to higher level thinking and memory. And then you also have your cerebellum, which helps regulates and coordinates your posture for balance and movement. And also the brainstem, which integrates those sensory information. So all that gets processed in the brain, and then that information gets brought out to our neuromuscular and musculoskeletal systems to stay balanced. So our visual system, it's external reference, telling the brain about the world outside. And we have these receptors in our retina here called rods and cones. And when light hits the rods and cones, they send impulses to the brain. And that provides visual cues of how we're oriented compared to other objects. So for example, we're in New York City, walking down the block, we know that those buildings is vertical. And so our somatosensory system, this is our primary system of balance for level surfaces. These are joint receptors in your ankles and hips. Tells you where you are in space. So, can I have a volunteer to come up? Anybody? I won't bite. Thank you for coming up. So, I want to give you an overview on what these three strategies are on level surfaces. Ankle, hip, and step strategies. So, on a level surface, our ankles are keeping us balanced, okay? Your ankles are keeping you balanced right now. So, our second line defense is our hip strategies. So, Marty, go ahead and give me a little push from behind. So you see, I threw out my butt and my hips kind of moved a bit because my ankles wasn't enough. to stay balanced at that moment. So my hips had to come into play, all right? All right, Marty, give me a little harder push. So that little harder push caused me to take a step forward and jump, and I'm out of my base of support, so all of a sudden I had to take a step to stay balanced. And so that's our stepping strategy. You can have a seat, thank you. So our, again, first line defense, ankle strategy, again, our ankles allow us to move in actually multi-directions, and so our hips as well, but our ankles are a little bit more efficient than our hips. Our stepping strategy is our last line of defense. That shouldn't be your first line of defense to stay balanced on a level surface, okay? If that's your first line of defense, then we have a problem and we need to work on your balance and work on your ankle and hip strategy. So we have a visual system for balance, or somatosensory, and now our vestibular system, okay? That's again in our inner ear. Our vestibular system provides an internal reference telling the brain where the head is in space, its direction of movement, and also acceleration. So that's where it provides sensory information about equilibrium or rotation, linear movement, and it helps generate reactions and responses to head motion through 3 different systems. First one here is the VSR, our vestibular spinal reflex. Those are postural responses to keep our body upright and prevent us from falling, okay? We have our VOR, a vestibular ocular reflex. Those are ocular motor responses allowing our eyes to remain steadily focused on an object when our head is in motion. So if I have my finger here and my eyes are right on that finger and I move my head side to side, I should be able to still focus on that finger, not be blurry and not be really dizzy with that. Another example is a football player, a wide receiver. They're running their routes. They have defenders around them. They have to make sure they're still in bounds, but they have to keep running, and once the ball is thrown, keep their eyes on that ball and maintain their balance, catch the ball, and so that's also the use of the VOR. Our VCR, vestibular colic reflex, is visceral responses to help keep our head and neck centered. So the best example I can give you for that is a video. So again, this is to show you what the VCR is. You see that chicken's head not moving at all, right? Their head and neck is very steadily stable, and their body's just moving all the way up and down, left and right, circles. And that's our VCR. So our vestibular apparatus comprises of 2 components. We have organs, our utrocolsaculum, that helps detect linear movement. So the utrocol helps sense the horizontal plane, so left and right, front and back type motions, with saccule helps with the sagittal plane, so up and down movements. And our semicircle canals that detect rotational movement. So that is where we have run into the issue with benign paroxysmal positional vertigo, or BPPV, where the crystals are out of place. So here's our ear. There's the eardrum, and then here's our vestibular system. The semicircles, the organs are right here. And a bigger picture. So here's our otolith organs, our utricle and saccule for, again, linear movement, detecting linear movement. To detect rotational movement, you see we have these semicircles. We have the superior or anterior semicircle canal. We have our horizontal semicircle canal, and then we have our posterior semicircle canal. So some issues or vestibular symptoms you may experience is dizziness or fogginess, nausea, complaints of increased of those symptoms in complex environments, like you're driving and you're trying to get onto the road and you have a lot of cars going by, and as those cars are going by is making you dizzy. Behavioral responses in relation to overstimulation, oscillopsia, which is blurred vision with head movement. You usually may say, like, I feel like my eyes aren't coordinated, or I feel like my eyes need shock absorbers. You become more surface dependent, like you are afraid to walk on grass or on level surfaces, or maybe experiencing vertigo. So as I mentioned earlier about BPPV, that's the issue where the otoconia or calcium carbonate crystals are stuck in the semicircles in the ear. Those are actually supposed to be in those otolith organs. So those crystals are supposed to be here, but for whatever reason, they end up falling down and they're in the semicircles. And that's the issue of having vertigo, of feeling that the room is spinning. Obviously, the room isn't moving, but because those crystals are out of place, it messes with how you're oriented, and you're not able to stay focused initially, going from a laying position to an upright position. So how to treat BPPV, that's actually essentially fixable. That's a mechanical problem. We need to get those crystals back into where they're supposed to be. So we utilize canalith repositioning maneuvers. You may have heard of the Epley maneuver. The only thing with that is it requires you to really extend your back and your neck. If you have any issues with your internal carotid arteries, like any stenosis in there, that's something I wouldn't put you in that position and compromise blood flow through the brain. So there's other canalith maneuvers that I'm certified to do that is a lot safer, a lot easier, and not as compromising as well. We can do sideline, we can do like rolling, just so that you not have to hyperextend your neck or back. So BPPV we consider as like a hyperfunction of the vestibular system. The room is going around in circles because the crystals are out of place. There's also other disorders that are more of hypofunction of the vestibular system. So the system isn't firing as fast and as quickly as it should be. So you can have issues like inflammation of the nerve that innervates the vestibular system, issues with shingles, Meniere's disease, which is basically like glaucoma of the vestibular system. Basically, to treat that is not the repositioning maneuvers, but to do vestibular rehab therapy. And what vestibular rehab therapy is, or VRT, we have systematic design protocols to go through to help reset or return that VOR, that vestibular ocular reflex, so your ability to keep your eyes focused when on an object while your head is in motion, to help improve that. Reduce exaggeration of motion or after motion. So basically minimize these movements that are causing you to feel dizzy. So, for example, you're telling me that rolling in bed, it makes you dizzy. So guess what I'm going to do with you? I want to make you roll in bed. We're going to, and we call this habituation. We're going to get into the habit of and kind of get you desensitized in that motion so that those symptoms of dizziness will decrease over time. We could also work on what we call the substitution. So strengthen the weakened system by reducing dependence on remaining ones. So again, with the Neurocom Balance Manager, I can assess your somatosensory, visual, and vestibular system. I can see which systems are weaker. Typically, your vestibular system, I've seen with elderly adults, is the weakest. And so, again, that works on level surfaces. So our vision, I'm going to eliminate your vision by what? Closing your eyes. And to eliminate the use of the somatosensory system, I'm going to put you on a foam pad. So by closing your eyes, you're on a foam pad. All's left is your vestibular system. So we're going to focus on that to help strengthen that. Or if you have an issue with like blood flow there, that it's just going to continue to be not as strong and be a little bit weakened, we'll just strengthen your other systems to make them as strong as possible to help compensate. So we're looking to improve your coordination of your head and eye movement and your balance and equilibrium. So here's some examples. Head circles with eyes open and closed. This is saccades, so holding a card in each hand and you're going to look at one object and the other. Body circles, rocker board, that's gaze stabilization, so turning your head with your eyes focused on that object, or sidestepping. Other conditions that VRT could help are migraines and concussion. So migraines is a neurologic disorder. And for VRT, we're talking about post-traumatic migraines. So these, which originate deep within the brain, send electrical signals to other places of the brain. The disturbances is that these blood vessels dilate, and then inflammation occurs in those surrounding tissues. And that inflammation irritates the trigeminal nerve. That cranial nerve is responsible for sensation in the face and motor functions such as biting and chewing. We can also help people with concussion, which is a type of traumatic brain injury. So a bump to the head or blow that causes the brain to move rapidly back and forth. Well, the thing with concussions, they don't usually involve structural injuries. So even though there's no structural injuries apparent because of that, imaging is not going to really detect a concussion per se. Basically what this is your brain goes through an energy crisis, an energy demand, which coupled with the decreased blood flow in the brain. So imagine with this egg here, the shell is your skull and the yolk is your brain. So imagine taking that egg and just shake it around, right? And you could do damage in that yolk inside the egg, but you can't see it because the shell itself is not damaged. So that mechanism of injury can result basically in all the neurological conditions that you see with people with concussion. So as I mentioned, it's more of this energy demand. So you need more oxygen, but you also have altered cerebral blood flow. So blood flow is decreased even though you need oxygen, which then reduces the neural function required for you to focus and think and to move safely. So finally, what I want to talk about is LSVT. LSVT stands for Lee-Silverman Voice Treatment. That's a woman. Her name is Lee Silverman. She had Parkinson's. The family just wanted to hear her talk. She had low volume in her voice, so they come up with this program called LSVT Loud as a speech therapy to help her to talk louder. And then they use those principles to develop LSVT Big, which is a PT and OT therapy. So the key features of LSVT is bigness or loudness, large amplitude, okay? So moving, taking bigger steps, everything exaggerated with their movements and even putting on clothes, and with talking or speech is talking louder. That also requires intensive and high effort. So I'll tell you on a scale from, or ask you on a scale from 0 to 10, how much effort you're putting in. And you're telling me, oh, I'm only putting a 3 or 4. And I'm going to tell you, you need to put at least an 8 effort. And so it's again, intensive. It's 4 consecutive days per week for 4 weeks. And each session is 60 minutes long. You have homework. So you have homework and exercises to carry on every day for 30 days. And then the third part is calibration. Basically what that means is to fix this mismatch between the perception of the output and how other people perceive it. So if I'm telling someone with Parkinson's to really try to move your arms and move your legs really nice and big, in their mind they're thinking, that's crazy. I don't want people thinking I'm walking like this, when in reality, they usually go from this to walking actually normal once they exaggerate those bigger movements. So for example, so everybody here, in your normal voice, say, how are you? Go ahead. Good. Now, in a loud voice, say, how are you? How are you? Okay, so your mouth open big, you have to take a deep breath in, and it kind of forces you to improve your posture a bit to really speak louder. So that's the cue with LSVT loud. And then that emphasis of that has translated to be utilized with LSVT big, is just to, so open your mouth big to speak louder, move your leg bigger to take bigger steps. These are examples of exercises. There's seated and standing exercises, so it involves going forward and sideways, rocking, to really open up everything. Because again, people with Parkinson's are generally kind of like hunched over and having difficulty just because maybe of tremors or stiffness, they have trouble with moving normally. So we're exaggerating from small movements to really large movements. So in summary, therapy early on can extend your ability to live independently, improve your ability to move, reduce pain or manage pain, restore your function, and increase your strength to help prevent future injuries or disabilities. Again, each one-on-one session is focused on you and your goals. You can get a referral for speech, occupational therapy, or physical therapy, and again, we have direct access as well. We do have home health therapy for those available that may have difficulty getting out of their home to outpatient and need services in the home. If you have any private questions or, again, want to be screened for balance, you can come to Oak Park and schedule an appointment with me. I can do a free screening with you. And so with that, do you have any questions? Yes.
It's not so much a question as a comment. Where you talked about visual component, you can have the best vision in the world, but if you don't look where you're going, you're going to trip.
Okay.
And I think that has to be emphasized. You come to it eventually under cognition, but it really needs to be right up there with visual and attentiveness.
Yes. So so that's part of cognition, your attentiveness and ability to filter out distractions. You have to use your vision peripherally to see where you're going, but not over-reliant. And what I probably actually should emphasize too is we're not trying to over-rely on your vision. I get that comment a lot, like I don't close my eyes. when you take a shower, you have to close your eyes for that moment and wash your hair, or if you're moving around in environments of low lighting, your vision may be, in a sense, quote unquote, impaired in that moment. So my emphasis on vision is that it's important, yes. It help you filter out distractions, look for objects or obstacles, make sure you avoid them, but it's not your primary usage for balance. Okay, so thank you. Any other questions? Okay, thank you.